Well, good morning, everybody. We're going to start today's session. If you're just joining us today, welcome to our biannual offsite meeting. We appreciate the active involvement of all the representatives of both our member and employer associations. So thanks for joining us, and just any members of the public. We hope you enjoy your meeting today. In a few minutes, I'm going to be introducing our Chief Executive Officer, who will share some remarks about our agenda for today. But before I turn it over to Marcy, I want to take a moment to thank the team from both our board services unit, the strategic events management unit, the video and live events communications unit, and our enterprise strategy and performance division. They've spent the last few months working on the agenda that we put together, pulling it all together, and making this event happen. So let's give them a nice round of applause for a job well done, please. We thank you very much for all the work. Board members, executive staff, as of about 5 minutes ago, there were only 19% of the surveys were turned in. And you can't blame it on the fact that we have computer issues at the office because it's on diligent. So let's get those turned in, please. And now I'm going to turn it over to Marcy.
Good morning, Mr. President, members of the board. Today we're going to talk about two topics. This morning we're going to be talking about healthcare. This afternoon we will be talking about enterprise performance reporting. And I'll, at the introduction of the enterprise performance reporting, I'll make a few more remarks at that time about that initiative. So both of these topics play a big role in our efforts to be transparent, efficient, and viewed as both a reliable partner as well as a best practice leader. And I think these topics, again, will invite meaningful discussion like yesterday did, and an opportunity to provide many viewpoints as we develop these initiatives to move forward. This morning, the panel is ready to talk with you about high and low value healthcare for ways that we can enhance and improve outcomes while effectively managing costs as well. And then we'll follow that up with a presentation on health beliefs. Leanna and the team have been doing extensive stakeholder work in gathering a draft of healthcare beliefs for the board's review today. We already have investment and pension beliefs, and as we discussed a couple of months ago, we think it's important that we also have healthcare beliefs for that very important policy area at CalPERS. And Leanna and her team will be leading that discussion. And then following our lunch, again, we'll delve into the enterprise performance reporting system. And this is timely because as of 2 weeks ago, we actually launched our new strategic plan, our 5-year strategic plan. And for the first time, you will get to see operational measures or key performance indicators for all of the operational areas at CalPERS, in addition to the strategic measures. So the team is very excited to share those with you today. So again, we have another full day, and I think the panel is ready to get started. So back to you, Mr. President.
Thank you, Marcy. So now we're going to turn it over to our Chief of Health Plan Administration Division, Kathy Donison, who's going to moderate our first session. Kathy, please feel free to introduce your panel, and let's move on.
Thank you very much. I'm Kathy Donison. I'm the Chief of the Health Plan Administration, and I have been working with both internal and external teams as we have looked at high and low value care. Our agenda today has a couple of themes I want you to think about. The first is that both consumer or patient or citizen and provider need to be engaged in terms of what is high and low value care. Secondly, they're out there in the community for all of us. There are both perceptions and then there's evidence. So as we look at high and low value care, 2 points I want you to bear in mind is that perception and evidence are not necessarily the same, and that it takes both a consumer or patient or citizen to be engaged as much as it does the provider. For our agenda today, we will look at high and low value care from different perspectives. We will have a question and answer dialogue at the end of the 3 panels presentations. So we'd like to ask our board to jot your questions down as we go through the presentations by each of our panelists, and to also think about the questions that are at the end of this presentation. 2 of the questions at the end of this session will be for our panelists to take 1 to 2 minutes to answer from their perspective. And then the third question we'll look at discussions we've had about how we redesign or think about designing either a new product or altering our PERS Select product. We've been down this road for the past year of value-based insurance design. In July of 2016, you heard from Dr. Mark Fendrick, who introduced the idea of value-based care, high and low value care, as being evidence-based, but also being a longer-term strategy in terms of having a value approach to how care is delivered, considering both cost and quality. In January, you heard from Robert Krish from Connecticut, who talked about the Connecticut approach to value-based design, in which members were engaged in two different types of health product. They had two different premiums. A lower premium if each family member engaged in age-specific screening, and a higher cost share if they did not. And the Connecticut experience was interesting because they thought that they'd have about 50% of their employees to continue to remain with the higher cost share option, when in effect they had almost 97% join the plan with the lower cost option, but required specific performance for health and wellness screening. We're going to talk at the end about the pros and cons of some of these different approaches, as well as pros and cons to our CalPERS, which the team presented in January, a different way to look at higher deductible plans with lower cost share if member or consumer behavior is changed. We have, and I am very pleased to have this distinguished panel with me today, Marge Ginsburg, who's the Executive Director for the Center for Healthcare Decisions, and I will introduce her as the first panelist. Jeffrey Rideout, President and CEO of the Integrated Healthcare Association. And Josh Fangmeyer, who's the Research Director at the Employee Research Division at the Minnesota Management and Budget Office. These three panelists will talk about value-based or value care from their individual perspectives. Marge will talk about the patient, the citizen, and the consumer perspective. Jeff will talk about how providers look at high and low value care. And Josh will talk about what they're doing in Minnesota in terms of a design of tiered providers. I am so pleased to have Marge here. Marge actually retired from her own organization, the Center for Healthcare Decisions, which she founded and served as executive officer for over 24 years. Marge has an interesting approach to looking at how citizens perceive healthcare and healthcare issues from a focus group perspective. So she has led thousands of focus groups with thousands of different stakeholders in terms of looking at conjoined analysis. What will you trade off if you want one thing? If you want that thing, what do you give up to get it? And so as she goes through her presentation, I think you'll thoroughly enjoy the fact that she has been unique in her research. And so I'm going to turn it over to our expert trailblazer for looking at the consumer perspective, Marge Ginsburg.
What's the forward, is that one? Good morning. And I'm very pleased to have been invited to present this. And the reason I'm presenting it, not the current executive director, is that this project I'm talking about was in fact done under my watch. So since I have most of the information about it, I was invited to come make a presentation. I do need to say this is the only thing I have done since I've retired that's related to my previous life. And I do this with a great deal of pleasure.
Can you do a sound check?
Okay.
Is our audio?
Just need to move it closer.
Closer? Okay. Great. That's okay. As Kathy said, Center for Healthcare Decisions has been doing this work actually since 1994, looking particularly at kind of a unique, unfortunately, too unique role of the citizen in terms of what they believe healthcare policy changes should be, why, and what the kinds of trade-offs are. a lot of our focus has been, not surprisingly, on the issue of cost and benefit design. This particular project, Doing What Works, was initiated in response to the interest of the three largest purchasers in California, Department of Healthcare Services, Covered California, and CalPERS. It came together in 2015 to try to get their arms around the problem of the overuse of low-value care, of which a lot of research had been done nationally and in California on the prevalence of this problem. So we were pleased to be asked to be involved in this collaboration with the idea of let's at least start with what do we know about the citizens' views on this challenging topic. Clearly, the Smart Care California, which is the collaborative that still exists and still works statewide, focusing particularly on certain interventions and certain strategies to reduce that. But we started with this deliberative process. I want to start in particular with just a reinforcing the difference between the patient perspective and the consumer perspective. Almost all work that has been done in this domain has focused on the individual patient, patient-centered care, understandably and rightfully so, because that, in fact, is where most of healthcare is delivered, with the patient's perspective being a critical piece to how we do this right. But the idea of the citizen voice hasn't entirely been squelched by our interest in individual care. But there's a very big difference between the two. Certainly the patient and consumer is oriented towards what do I as a patient need to know? What are the trade-offs I am willing to make? What is in my best interest? And how does my provider and my health plans work to deliver what is important to me as an individual? For the citizen, oh, I think I forgot the, oops, sorry, back up. The citizen, however, has a different angle. This is the same person as the patient, but they have a different question to answer. It's not what is in my best interest as an individual, but what is in the best interest of all of us. We're basically asking them to become policymakers and to help inform the actions and the interests of, in fact, the folks who are creating the health systems that are going to work best for them. So the question to them is not what is important to you, what do you want, what do you need to know to make good personal decisions. Rather, it is, here is the problem, what should we do about it? Oh, I'm missing one. That's okay. The slide that was going to be up here was just reinforcing the role of this project, Doing What Works. And I also wanted to acknowledge the two funders for this project, California Healthcare Foundation and Kaiser National Community Benefits Fund. So the we are really out of order here. That's okay. Addressing overuse with the public then, the reason this makes it a bit of a challenge is we're asking them to think about a problem and the various responses to it in ways that almost inevitably are going to challenge certain core social values that most people hold dear. Those values are the autonomy of individual doctors, patients' access to all treatment options, their right to decide what has personal value to them, trust in their individual physician to deliver high quality care, and yes, they do think about the effective use of resources, both theirs and society's in general. Okay, so this is the slide I just wanted to mention. This is the cover of the full report, and I will reinforce this at the end. I think you all got a copy of the executive summary, but I really urge you to go on to the website and look at the full report, which is provides a lot of additional information. So our learning objectives for this project is, to what extent does the public accept medical evidence as a valid reason to set limits on unnecessary care? Are some approaches for limit setting more acceptable than others? Are there some types of medical interventions that are more acceptable to limit setting than others? And do differences in perspective vary according to sociodemographics? The sessions we held were all held in 2015 and early 2016. There were 10 sessions held throughout the state, each 4.5 hours long. As it says here, 5 sessions with Medi-Cal members, and 2 of them were conducted in Spanish. 4 of covered California, and 1 session with CalPERS members. All of them were low to moderate, this in ages 30 to 60. We didn't want any dual eligibles. Diverse health plans, which was very important because we wanted to make sure we had the experiences and the perspectives of people and how they related to the health care they currently got, and none of them worked in health care directly themselves. We recruited participants through market-based organizations, some community-based organizations, and all participants were provided with a $200 stipend for their attendance. Before you start deliberating on any topic, a key element is education. People cannot talk about high value or low value care without having a pretty solid grounding in what these terms mean and how they apply to the world they're in. We developed 4 educational handouts. The rising cost of health care, a focus on value, what is low value care, and included in that one was why does it happen? Why does so much low value care happen? And ending on medical research, because as I think all of you know, research is what drives all of these. They reviewed the materials, they discussed them, they talked about how these things were relevant or not, and it really gave people a chance to understand much more clearly what the issues and conundrum were that they were facing in this discussion. We decided to use 3 case scenarios. We actually used a 4th, but I'm not going to get into that one unless you ask. These were the 3 major ones, and these ones were particularly important to our the head purchasers in California. Use of antibiotics for adult bronchitis, C-sections with normal pregnancies, and use of MRI scans for low back pain. None of these should be surprising to any of you after all the time that has been spent in talking about these as particular candidates of low value care that needs to be changed. The key part in presenting each case scenario, and each scenario was presented one at a time, not all together, and in each one we included what the problem was, what the issue was, how big an issue it was, what the individual and societal harms, and what the total cost was for each one. We then asked them to look at several different approaches and decide what they thought made the most amount of sense for remedying the problem. And these were the 4 categories of approaches. They were all worded a little bit differently depending on the case scenario. The first and biggest, obviously, was that of provider-facing and greater oversight, greater monitoring, having to do with what physicians were actually doing. The second was also provider-facing, but focused on compensation. Should they be rewarded for doing better care? Should they be penalized for doing not so good care? The third was patient-facing. Should we make these changes using patient incentives, either disincentives or rewards, to get patients more oriented towards the more appropriate treatment decision? And of course, the last option was do nothing. Don't do anything more than is already being done, because there might be any number of inherent dangers in taking more of an approach. So I'm now going to talk about the results. We did an intensive quantitative and qualitative review of all the transcripts and all of the data, and I'm going to be presenting both the quantitative and qualitative to you in a very general sense. So the first one, under provider-facing greater oversight, this was clearly the intervention that had the greatest appeal to people. And their main reason was that they saw physicians as being professionals. And as professionals, they needed to be taking actions that were consistent with the professionalism that was inherent in their position. That could mean retrospective review or prospective monitoring of data, but really focusing on what the physician was doing and using physician leadership to correct aberrant practices. So it was basically saying to the docs, this is your mess. This is up to you to fix. The provider facing that focused on compensation had much less enthusiasm, we should say. And in fact, the side of compensation that focused on rewarding doctors for good practices was really demonized. They, in a word, they hated it. They thought these are professionals. This is a position we hold in highest esteem, and we're going to bribe them to do the right thing? I don't think so. It really just completely annoyed them. I can't begin to tell you some of the quotes that came out from that. Interestingly, the decision to penalize physicians for doing the wrong thing wasn't viewed with quite as much hostility. They still didn't love it because they don't like equating performance with money in any way. They just think that's the wrong approach to take. But it was a little bit more enthusiasm than rewarding doctors, particularly as it pertained to C-sections, where they read the data and they saw that this was really being driven more by physicians and hospitals than it was by patients. And they thought perhaps the only way to put an end to this is to quit paying them so much money for doing unnecessary care. Patient-facing incentives or disincentives, that was very much a mixed view on this. On the one hand, they really thought medical care, first and foremost, belonged to physicians. They're the ones writing the prescription. On the other hand, they really hated the idea of giving up all patient choice. So the idea that if a patient pays more for an intervention that is not as effective, that was okay because it kept the patient's choice alive. They weren't told no. They said, yeah, you can have it, but you're going to pay twice as much. So they regarded that as a more acceptable approach than simply out and out saying, no, you can't have it. They didn't like rewards for doing the right thing for the same reason they didn't like it for doctors. And the last was take no action. We've done a lot of projects dealing with the trade-offs between cost and benefit. But I have to tell you, I was surprised that only 9% said don't do anything. More than any project we've ever done. And I think the reason it was so low is that the evidence was so strong about what this is costing them and other members of society that simply ignoring it was no longer an option. Those that did say take no action was usually not because they didn't believe there was a problem, but they were more worried that the solution was going to be worse, that was going to lead to rationing, lead to more draconian interventions that would squelch the patient-doctor relationship. So they weren't quite ready to give that up. So the dominant themes, I'm really sort of summarizing a lot of the things I've said earlier. First is that physician leaders are responsible for resolving this problem. So that's the message. Monetary incentives are inconsistent with medical professionalism. Higher costs, patient cost sharing may be justified simply to maintain freedom of choice, but obviously that has to be done selectively. Interestingly, where there was most debate was around the C-sections. This was the area where participants really wanted to keep the woman in the picture in terms of being the decider, but a whole lot of people thought that it was simply unethical for physicians even to do an unnecessary C-section if in fact it may be causing harm. That the ethics of doing no harm really was a greater need than the need to give patients all of their choice. So this was great debate. There was no one end to this. Responsible use of shared resources dominated the discussions. Even though there was a lot of discussion of individual and societal harm around overuse of antibiotics, they got it, they understood it, but it did not resonate in the same way that the cost to them. Remembering these are all low to lower middle income participants. And the last is that the citizen voice is not the same as the patient voice. I didn't have to point that out. They would point that out. They would say, if it was me, the patient, answering this question, I'd say take no action because I don't want anybody interfering with me and what me and my doctor decide. However, you're asking me to be a policymaker, and we can't afford to do that. That's the wrong decision. So as a policymaker, we have to get our act together and reduce that. But the fact that they so clearly saw the distinction and they liked being policymakers, I must tell you, this was a role they loved, having somebody come and ask and knowing that these results are going to be presented to leaders like yourselves. I want to talk just the last bit then on the difference between the patient and the citizen. So we had a lot of pre and post questions to assess differences in perceptions and value and knowledge and beliefs. One of the questions, and this is the one that was most explicit to them, the patient, if my doctor and I agree the best treatment, blah, 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 health plan should pay for it, no matter what the research shows. You can see here the pre-survey responses, 76% said, yes, health insurance should pay for it. That dropped to 65% after the discussion. That's not a tremendous drop. And my assessment is because they are still looking this as a patient. We ask the same question, but we take out my doctor and I. Health plan should pay for any treatments, yada, yada, yada. 55% agreed at the start, and that dropped to 27% at the end. So more than anything else, you can see the tremendous difference. And we all wear different hats at different times, and so do patients and citizens. So just, I'm throwing this open. We're not going to be answering this right this moment, but I think that's going to be part of the discussion later. Are these principles reflected in current policy and practice? And here certainly are some of the ones that are currently being used in the state of California. So I'm not going to answer it for you. And in fact, we're not doing questions now. We're going to wait till later. But I do want to encourage you all to go online and see the full report because I think you will find it fascinating and will provide a lot more detail and nuance than I was able to do just now. Thank you very much.
Thank you, Marge. Thank you for that very interesting discussion on the consumer, citizen, patient perspective. I'm now going to turn to Dr. Jeff Rideout, who is the president and CEO of the Integrated Healthcare Association. He is also our sponsor for Smart Care California. And to remind you, Smart Care California is a coalition of 3 state agencies. The Department of Healthcare Services, who's managing and looking at and reshaping our thoughts about opiate abuse. Covered California, who is looking specifically at C-sections and how to reduce the C-section rate in California, and CalPERS, that is looking at low back pain and non-invasive and evidence-based approaches to managing acute and chronic low back pain. We also value the Integrated Healthcare Association value-based pay for performance methodology. It's an alternative payment system that we find is innovative and timely because it doesn't just look at cost and quality. It looks at quality measures, clinical measures, resource consumption, which is the cost component, patient satisfaction, and meaningful use, the use of integrated medical record systems. He's got an extensive biography, which we've provided for you. I've worked with him in his work with Covered California, Blue Shield, and many other aspects of his extensive contribution to healthcare in California. So I'd now like to turn it over to Dr. Rideout, who's going to talk about the provider perspective.
How's that? Better? Thank you, Kathy. First of all, a number of thanks. It's a great pleasure to be here. And thank you to the board and for inviting me. I also want to thank a number of the CalPERS management team that participate with our programs. Leanna is your board representative. Kathy and Richardson participate actively in Smart Care. David Cowling is helping us with our ACO program, and I'm sure I'm forgetting folks. But I wanted to give you just a little context to IHA because a lot of people don't know what it is. But we are a 501c6, and for reference, that's by tax code a business league. And what that means is we are organized solely for the benefit of our combined members. And we have 40 voting members, including all the major health plans, all the major risk-bearing provider systems, all the major hospital systems in California. We have pharma companies. We have a number of non-voting members. In fact, a founding member, Jamie Robinson's in the front row from academics. We have the head of the Department of Managed Healthcare on our board. I'm saying all that not to impress you so much as to say, trying to find anything that everybody wants to work on that's in their mutual interest and is not considered a competitive issue, it's really, really challenging. And so I'm going to highlight a couple of the programs where I think both the spirit of what we're trying to do in California is really quite evident, and also where the information could be quite useful to CalPERS. I would also mention that we are fortunate to have several CalPERS alumni on our board. So Doug McKeever is representing Covered California, and Ann Boynton is also on our board with UC Davis. So we do have quite a bit of a lineage within California and with CalPERS. I think the thing that makes that helpful is a lot of my experience in California is based on personal relations and common objectives, regardless of where people work and where they change to. And I think that actually goes a long way to helping some of these programs both continue and also grow. So one quick thought on 501c6. I was not aware of what a 6 was. There are actually 39 different 501cs according to the tax code. Most people are familiar with 3s. The one in healthcare that a lot of people have probably hear about is HIMSS, but the other one is the NFL. So I don't know what that means, but we're in that same bucket. I'm also a firm believer to kind of keep the messages short and sweet. So if you really want the key takeaways from IHA's perspective, to even assess high or low value, you have to use standardized measurement and benchmarking. There's absolutely no way you can make credible conclusions about what is good or bad value or high or low value without actually having some standardized metrics and benchmarking to organizations not only within the regions and the state that you're working in, but outside. So a lot of our work draws on the Minnesota Community Measurement Programs and other groups like IHA that exist around the country. The second thing I'd say is integrated care, however it's defined, however it comes through a product that a health plan offers, however kind of cliche-ish or newish or faddish the labels are, integrated care provides superior value. I believe that for years, but I think the data I'll show you actually will show you that that's quite true, at least in terms of the information that we collect. And then the third thing I'd say is a lot of these conversations tend to be kind of theoretical. This is real information. You can use the data that we provide now, and CalPERS does use a lot of that data to actually make decisions about what you think makes sense in terms of high or low value care. So hopefully that'll make some of the information kind of jump off the page a little bit. This is just a reminder to myself, actually. Every organization needs to know what it's there to do and not do. And we did some very extensive market research as recently as this January, where really our board and actually the extended stakeholder community we serve told us what our swim lanes are. And really the long and short of it is keep bringing us together because we learn a lot from each other, do it in a credible way. Also, keep measuring and benchmarking. Don't try to get into being an HIE. Don't try to get into predictive modeling, big data, all of that stuff. That's all great. But what we want from you is essentially the credibility and the trust that comes from being a independent third-party organization. And oh, by the way, if you can help us with the things that even go below the basement of just measurement into the sub-basement of just how to collect data, we'd love that too. So as you probably know, there's a number of initiatives within the state now that the Department of Managed Healthcare is driving through some of the merger requirements that are really looking at big problems like provider directories, encounter data, infrastructure support for low-income communities and low-income providers. So that's kind of where we play, and it isn't always the sexiest thing. I teach a class at Berkeley on venture investing in healthcare, if you can believe that. That's all the fun stuff, big data, digital health, all that. This is not the fun stuff, but this is sort of where the information either comes or doesn't come in a way that is actually useful to what you're trying to do. I'm not going to read the slides. I'm just going to reference them so you can look at that. This is our newest program, and I'm going to talk about just 3 programs. This is the Cost and Quality Atlas. This is a remnant of the recently non-funded federal CalSIM grant that the state of California submitted. So this was what Diana Dooley wanted to keep alive, and the California Healthcare Foundation funded it. And it's essentially the Dartmouth Atlas for California. We're looking at cost, quality, and utilization variation across the entire state and across different lines of business. So HMO versus PPO versus Medicare Advantage. I'll show you the results, but this is, as far as I know, the largest, one of the largest atlases in the United States, but it's certainly one of the most relevant atlases to sort of the variations in care that we know exist in California. And one of the takeaways on this, before I actually show you the data, a lot of this information, for those of us that have been in the industry, whether it's on the plan side or the provider side or the delivery system side on the hospital side, it all is like, oh yeah, I knew that. I knew it was more expensive in Northern California than Southern California. I knew that this was really driven by price as opposed to utilization. But this actually brings that out explicitly, and we hope in a very objective way so people can respond to it and use this information as they create narrow networks, as they create new benefit designs, as they think about what to push on hard, what to kind of work with a little more softly. So the goal here was not to expose anybody, and I think I should also reference the 10 health plans giving us the data to do this are doing it all voluntarily. So there's no coercion here. There's no, gosh, you've got to do this because it's a mandate from the state. This is all because people want the information to come out so they can do a better job. The question is, how will we use the information as it starts to come out? So again, for those of you who like to jump to the chase, the key atlas findings are integrated care is superior value to non-integrated care, especially when you include patient cost sharing. One of the things that this program did was it looked at total cost of care using a national quality form standardized metric, which is also used in Minnesota. I keep thinking of you as the Minnesota guy, but and it basically said when you include the amount of money that patients pay for their care with the amount of money that's being paid by plans, that's the most inclusive definition of cost. If we start looking at it as just the cost the plan pays or premiums or things like that, you start to skew the results in ways that don't include all of the costs involved with care. And when you look at quality for HMO products, now this is 2013 data, you're saying, wow, that's ancient. But the good thing about that is it's pre-ACA. We're getting 2015 data this year. And it also is at a time when most of the integrated care was delivered through an HMO product. A lot of that got confused and blended, and high deductible HMOs and ACOs and PPOs. So what we've done is we've essentially created a meaningful baseline of where integrated versus non-integrated care, how it performs. And so what we're really looking forward to is the next round of this. The striking thing about our data was in every region of the state, HMO quality, if that represents integrated care, was vastly superior to PPO quality or non-integrated care on the 6 measures that we looked at, which are representative of chronic care management and preventive health. The other striking thing was, for the most part, cost was actually on par or even a little cheaper on a regional basis. So what that told us is when you include that patient cost sharing, actually HMO and integrated care can be affordable. It just depends on affordable to whom and affordable to whom. The other thing that came out very strikingly, and there's a series of blog posts that I've done on the California Healthcare Foundation website that looks at each of these in a little more detail. There's striking variation in quality and cost regardless of product type, and the price of services is driving that cost difference much more than the utilization. So again, this is one of those, yeah, I knew that, sorta. But the information basically confirms what I think most of us understand. It's not about what people are getting as much as necessarily, it can be, but it's also about what it's costing people to get that care at one place versus another. So this is a graphic representation, but again, if you're looking at this, the black lines are averages for the state, so they're normalized. So the center of the graph is sort of average for quality and average for total cost. The higher quality, lower cost options in the upper left are actually all HMO regions. So this is a regional analysis, whereas the lower quality, higher cost, sort of the lower value, are actually all PPO products in different regions. So that was one takeaway. Another takeaway is if you look at all of this, where do we see that kind of perfect blend of higher quality and lower cost? Actually, it's in more of the Southern California regions, and that one with the double circled there, looks sort of like a target. That's actually San Diego. And some of the things that are interesting about San Diego are it's driven largely by integrated care systems for the most part, and it seems to match the total cost of care of Southern California while also matching the higher quality that we see in general in Northern California. So the other thing I'd take away from this is that there's lots of stories behind this, and what we're going to do in the next round is actually provide what are called vignettes, so people can kind of pick the type of story they're interested in. But all of this information is downloadable. You can take it all right off our website and look at the rates by region, by product line. What we hope to move toward is actually by plan name and by provider name. But again, because this is voluntary, those are the steps in transparency that a lot of the contributors are most nervous about, quite rightly. The next program I want to talk about is our value-based P4P program, and this is the grand old lady of our existence. It's been around since 2003. It's gone through a lot of changes. It was originally a quality incentive program. It's now a value-based program that looks at over 200 risk-bearing medical groups. So if HMO in some ways has superior value to PPO, this is sort of, well, how do those superior organizations line up against each other? And that context was really, really important for folks because previously a lot of this information was kind of like who's high and low relative to each other, and we're kind of ignoring half the market. But as the market moved to PPO and as most of the HMO moved to Kaiser Permanente, it really became important to say, well, how are the integrated groups, in this case in value-based P4P, performing against the market in general? So again, another voluntary program, huge spread across medical groups and health plans. And I will say to reinforce one of Marge's points, the incentive component is actually pretty weak. This is the largest alternate payment model in the country by statistics like number of plans and number of enrollees, but the incentive is actually a small part of it. And one of the things that we've had to do over the last couple of years is help people not only get used to the value theme, but also understand this is about performance improvement and performance measurement. If it's all about the money, doctors in particular don't respond to those signals in the way that you'd want them to necessarily. It's too crude, it's too blunt an instrument, and really this is about performance improvement. So within this, there's a lot of information about who's performing well, but there's also a lot of information about who could improve their performance as well. I'm going to stick on this slide just a little bit because I think it has some really important messages for folks here. If you looked at the gains in quality improvement, looking at that for this program, actually over the course of just the 7 years since 2008, tens of thousands of people have gotten screened, have gotten appropriate care that they wouldn't have gotten otherwise, especially if they're not in integrated groups. So this group, this cohort of integrated care organizations are moving in the right direction. It may seem incremental year over year, but relative to the non-integrated groups and relative to their own performance just a few years ago, they continue to improve in general. The success of the highest performing groups, like those ones that were highlighted in San Diego, you could screen 40,000 more diabetics a year. You could save $4 billion a year. And now that's all modeling. So that's sort of like, well, if everybody did everything perfectly, this is if everybody just got to the higher quartile of performance, we would actually see some tremendous savings. And remember, these are the groups that are already performing well on quality. There's lots of opportunity to target. So this is sort of use the data. One of the things I did when I got to IHA a couple of years ago, I was on the board for 10 or 15 years, and it always drove me nuts that we were always looking at the best performers when we had all this information on those that didn't perform as well. There are about 700,000 people trafficking through medical groups and IPAs that actually underperform year over year. So what can we do to actually drive interventions across the common measure set for those groups in particular? And we have that information. The other thing I'd say about the program, and again, this gets back to standard measurement and benchmarking, without the program, half the health plan rates for provider groups wouldn't meet validity standards for measurement. And what that means is you couldn't trust the results. So I'll give you one example. It's an extreme example, but in our measurement of colorectal cancer screening, for one health plan, the rate at a particular physician group is 15%. For another health plan, both of scale, it's 85%. And the combined rate is about 58% when you put all the plans together. So parsing this up by plan, parsing it up by employer group, actually can cause some misinterpretations of data. This is a subset and a new kind of diversification of this program around ACO measurement. And so as the market moved away largely from HMO purchasing to, with the exception of Kaiser, to PPO purchasing and self-funded employers, ACOs became kind of the bellwether for where good care could be delivered. One of the messages I'd leave you with, the only thing we know about ACOs is how to spell them. That's it. There is nothing that says because somebody says they're an HMO, they're delivering better quality, better value, more cost effective. In fact, some of our data, which Rand has looked at, would suggest that the groups that perform the most poorly on total cost of care actually have more ACO contracts than those that perform better. So somewhere in the soup of what is an ACO, how do we do attribution, we need to figure out how to measure that group, especially if that becomes one of the ways that people access what they used to get through an HMO product. So it's very, very important to do that. There's also a whole industry around measurement of ACOs. This looks at just 6 or 7 of the different measurement subsets. We're trying to come up with a combined set with support from CalPERS and PBGH, as well as our plans and providers. Long story short, nobody is implementing a standard set, and nobody's even implementing the set that their own trade organizations are promoting. So we're kind of at a nice window where if we can build on the history of value-based P4P and apply those measures and add to them in ways that organizations like CalPERS want to advance the process, we can actually get to a standard set relatively quickly. The other, yeah, I'm sorry, JJ. Mm-hmm. Sure.
I know you want questions at the end, but on this slide, can you tell me what those acronyms are?
Sure.
I mean, ACO, I know, but
So I'll give you just a couple of them. The top one is various health plans oftentimes define their own measure set in terms of how they want to contract with ACOs. The challenge with that is each of those major health plans is defining a unique set. So if you're a medical group that's trying to provide integrated care, it's nearly impossible to kind of keep track of all the measures. And we've literally had meetings where the people will bring paper charts that will cover that entire screen on the measure sets they're being asked to keep track of. So part of this is people won't improve what they're not focused on. The second one is from CMS. They've joined with AHIP, which is the trade association for the health insurance plans, to come up with a core set. The problem with that core set is that nobody's using it yet. So one of the things we're trying to do is not only coordinate across the plans, but coordinate across national sets like this as well. And then the others are just other either government or industry programs that are trying to do much of the same thing. So we're not trying to take ownership of this. We're trying to say, can we find a way to consolidate this? And that number 59% with CMS AHIP, after our meeting last week, which CalPERS participated in, we've gotten that up to about 75%. The key thing is there's a lot of things that we know we need to measure, like total cost of care, patient-reported outcomes, C-section rates, opioid overuse, that a lot of these sets don't have. So we're trying to push the envelope on that in a coordinated way. Does that help, JJ?
yeah.
The other thing on the last thing on the ACO sets that I'd like to say is we can't ignore what we have learned over 15 years for the sake of what is trendy or faddish. So I'm on a number of national organizations where just because you label something an ACO doesn't mean it doesn't reflect what's been going on in our market for 20 years. So if you look at the organizations that call themselves ACOs, over 80% of those organizations, at least by name, actually are already participating in our value-based P4P program as an HMO group. So what we're trying to say is, why would we ignore that 13-year history of performance information for the sake of saying, well, they're not ACOs because they don't label themselves that way. So part of this is actually taking advantage of the history that we have here in the state. The last thing I wanted to point out, which Kathy mentioned, is Smart Care California. This is a coalition that includes Covered California, CalPERS, and DHCS to look at 3 areas of overuse: C-section rate, low back pain management, acute low back pain management, and also opioid overuse. And it builds off of the work that Choosing Wisely has started nationally. And this got started actually when I was the medical director at Cover California. And it was, I think, just understood between DHCS and Cover California and CalPERS that as large as those organizations are, they can get even more done in certain areas if they work together and if they have common messages for primarily for providers and health plans. So there's a lot of people involved in this. We're getting great traction on C-section in particular and low back pain with Kathy and Richard Sun's leadership really starting to take off and take advantage of other states. There's a lot of great information out there of what people can do. And what we're trying to do at IHA is expand the net, so to speak, of people that are involved. So we're actually interviewing self-funded employers to help them be educated about smart care that have a large presence in California and see if they want to start to participate as well. So that's, I think, more of an educational forum, and it's more a voluntary participation. It's not as structured as the two programs I mentioned, but it's another way that we can start as an industry to move some of these things in a way that people actually come to terms with pretty quickly and want to support. So I will stop there, and I'll turn it over to Joshua. And I will come back. I know one of the questions that has been floating around was, what's the relationship between high-value care and high-deductible plans? And I think some of our data can help shed some light on that, but I'll hold that until we get to the QA.
Thank you. Thank you, Jeff. As I said, we've worked very closely with the Integrated Healthcare Association, and we've actually worked with each other in different roles, wearing different hats. And before I introduce Josh, I want you to think about PPO versus HMO plan design, because we're going to come to that towards the end. And what Joshua Fangmeyer is going to talk about is their approach to value-based insurance design using provider tiering. And as we met yesterday to have a conversation about how to manage providers and care and practice to evidence-based medicine through a PPO product, which is what he's going to talk about when he talks about tiering the physicians with a PPO benefit design. We have large areas within California that are integrated, as Jeff described, and integrated care is something that we have worked towards in our HMOs, but also our PPOs. We have a PPO plan design so that we can ensure that all 58 counties in California, plus the United States, plus the world, have access to health care insurance. So that's the history of our PPO design. It's fully at risk. We're fully at risk. It's our plans. And there are going to be some similarities in terms of what we have faced as a team in making sure care is integrated even in the rural north, the eastern part of the state, the central coast. Those are the struggles that we face in terms of how to make sure we're delivering health insurance to all of our members within California, the United States, and those that are situated throughout the world. Now let me introduce Josh Fangmeyer. He's the research director of the Employee Insurance Division at Minnesota Management and Budget, and he leads the research and data analytics unit for the State Employee Group Insurance Program. And they have about 128,000 active Minnesotans in their plan. As I said, in Minnesota, their approaches to the VBID strategy is to tier providers, and he's going to talk about the program that has been in place actually for about 15 years, and how they not only manage the tiering of those providers, but access of the members to those providers in a state that has similarities with California in terms of delivering care in rural areas, suburban and other metropolitan areas. So I'm going to turn it over to Jeff to talk about the purchaser perspective and to talk about the approach that they took to value-based insurance design.
Great. Can everyone hear me okay? Okay, great. Thanks, Kathy, and thanks to the board for inviting me. I really think it's just great in the spirit of states sharing ideas of different types of models that work. I'm really glad to be here today to share our experience so far with running a tiered network benefit design for Minnesota state employees. And And I also want to say we're really interested in a lot of the programs and models that CalPERS has implemented, particularly reference pricing or things that we're looking at very closely and are very interested in as we continue to push value-based care for our population. So most of my time today is going to be talking about the Advantage Plan, our tiered network product that we've been running since about 2002 for the 127,000 total covered lives in our self-insured group. We also have a separate group that is about 23,000, mostly in local government units, counties, local school boards, that we use to run our tiering modeling, but is actually a separate book of business. But I just wanted to make that point clear. Our model is a more traditional gatekeeper model where members select their primary care clinic during open enrollment every year. And in order to get specialty services, they must get referrals to get specialty care. A couple features that are more friendly to our members is that members can change their primary care clinic choice anytime during the plan year. And family members who are under the same contract can be signed up with different primary care clinics and can also change clinics at different times of the year. And they can be at clinics that are at different cost tiers as well. Overall, we have a very broad network in providing a lot of choice for our members for the primary care services that they're looking for. But we do, through our tiering model, have these incentives baked in to encourage members to sign up with lower cost providers. Just a quick overview. Again, 127,000 covered lives. We do have a very small portion of our pool that are pre-65 early incentive retirees, mostly state employees who had worked most of their career in public safety, but otherwise we don't have any traditional retirees in our self-insured group. We have 3 different third-party administrators. Blue Cross Blue Shield of Minnesota is the largest one, but we also have Health Partners, which runs somewhat of an integrated care delivery model, and then Preferred One, which also has really strong provider relationships, particularly in the Twin Cities. So here's an example of our benefit design showing the differences in cost sharing for members at the different cost levels. So we have cost level 1. So cost level 1 is a designation for the most efficient, high-performing primary care clinics. So as you can see, the office visit copay for members who have signed up with a cost level 1 clinic is $30, but goes up to $85 if they've selected a cost level 4 clinic. And then as well, deductibles and out-of-pocket maxes vary considerably by cost level. And one thing we've actually done in recent years is we've increased the spread in cost sharing between the lowest cost level and the highest cost level to really encourage members, when they have a choice, to move towards lower cost providers. Again, we have these variations in cost sharing to really encourage members to sign up with low cost providers. But the strategy is also provider facing at the same time. It really brings providers to the table to negotiate with us to get a better tier placement for the next plan year. And CGIP, the program that we administer, has long negotiated these special deals with providers. Traditionally, the deals have been a reduced fee schedule that is negotiated usually around this time of the year for the next plan year for providers to accept lower reimbursement in order to get into a lower cost level and to get more patient volume. But more recently, since about 2013, CGIP has been engaging in some risk-sharing, shared savings arrangements where it's a combination of an upfront fee schedule reduction as well as setting some targets for spending levels in the future. So that's been something that we've worked on and are still working to continue to refine that type of payment model. So how does tiering work? We do have these 4 cost levels, and what we use is a total cost of care model. So it is holding providers accountable for all paid claims for members who have signed up with their primary care clinic. So it includes prescription drugs, costs of referrals and specialty care for services being delivered outside of the primary care clinic, but really holding that provider accountable for the total cost of their membership. We make some adjustments for risk across the populations, understanding that certain providers are going to tend to get more complicated patients. And then we also, for cases that cost over $200,000 a year, we top code those members, so we're not holding providers totally responsible for the cost of a lot of high cost care that can be very random and that they may not really have a lot to do with directly. The data analysis that for our tiering is run in April of every year, and we use the prior year's claims. So this last April, we used 2016 claims experience, and then using some internal modeling that our consultants get from our third-party administrators, projecting the fee schedule increases for all the different care systems. We make projections on the 2018 costs for various providers that are in our network, and then that determines what tier that they are ultimately assigned to. So we have different care systems that we use with our tiering system, and we apply this a little bit differently depending on how many of our members actually sign up with those primary care clinics. So at care systems where we have less than 10,000 member months, think of these mostly as rural, more independent, freestanding clinic systems that don't have business arrangements with larger care delivery systems. We group these independent clinics together by region and pool all their experience together to determine their tier. For care systems that have more than 10,000 member months, we are able to just look at that business unit, that care system, and then determine their tier. But for much larger care systems, these are mostly systems that are around the Twin Cities. We look that have 10,000 member months with each of our third-party administrators. We actually vary the cost level tier designation by third-party administrator. For example, Fairview Health System, which is one of the larger ones in the Twin Cities, could be at different tiers with Blue Cross compared to Health Partners compared to Preferred One. So in that way, it also rewards our third-party administrators who are able to negotiate more favorable contracts on our behalf by driving more membership to those administrators. So in terms of our analysis steps, as I mentioned, we take our claims data from the prior year, we apply risk scores and outlier adjustments, and then we ultimately develop this relative efficiency score based on total cost of care. So because it's a relative efficiency score, we're basing the tiering on the statewide average risk-adjusted total cost of care. So what that does is it creates some interesting incentives where a care system that is able to keep its costs the same or maybe a very modest increase could actually go down to a lower cost level if all their other competitors have larger cost increases. So it is really based on their relative performance compared to their competing systems. Again, this is just some sample results. I don't think any of this data is actually real, but it gives you a sense of how it works. So we have all these different provider groups, these care systems that we're using for our tiering model, and then we have these thresholds, the three thresholds which divide up the four cost levels, and the four tiers, I should say, into cost levels 1 through 4. And the breakdown, I did a quick look this morning because I was just curious. So only about 7% of our clinics actually get a cost level 1 designation. They have to be doing quite a bit better than average in order to reach that level with the lowest cost sharing for members. And about 14% of our clinics are designated in cost level 4. But most of our clinics, about 59%, are in cost level 2. So after we've done this analysis, we start working with providers to bring them to the table, potentially negotiate, and come up with the final clinic directory with all the cost level designations. So we start this in the early summer where we send letters out to about 600 different providers, telling them what their initial tier assignment will be for the next plan year. We give them information really describing what is driving their designation of their cost level, whether it is their prescribing patterns, whether it's inpatient utilization, physician services, everything that is included in total cost of care. We really show what the relative performance is at that amount of detail. And then we give them comparisons to other providers and also information on their referral patterns. We then invite providers then to negotiate for a lower cost level designation. And that's happening actually for us right now, where providers will come to us and either propose a fee schedule reduction or the risk sharing arrangement, as I mentioned earlier. And then after that whole negotiation process is done, we then go through our whole clinic network with a fine-tooth comb, and we have to make access adjustments as part of our labor contracts with our labor unions. We guarantee access to a cost level 2, at least a cost level 2 clinic within 30 miles of every work site in Minnesota. And then we sit down with consultants from the labor unions to look at which clinics within those regions or within the radius of those work sites should be adjusted to provide better access to lower cost sharing for state employees. And some of the results, we do know that enrollee cost sharing does influence member choice of the providers that they work with, and that it also brings providers to the table. About 15% of our members are enrolled at a clinic that negotiated a deal with us in the previous year. But one of the things that we're really excited about is a study that's funded by the Robert Wood Johnson Foundation with researchers at the University of Minnesota School of Public Health that is looking through 15 years of our claims data and really trying to understand what is driving consumer choice in the clinic selection process, as well as what is driving providers who are coming to the table to negotiate with us, and really trying to understand how this model is really working and really trying to get a better sense. We do know from other research, particularly in Massachusetts, where there's been some tiered network products, that there is typically some cost savings associated with implementation of a tiered network, but we're really trying to, with this evaluation, put some harder numbers behind what the actual experience has been like for our program. Here's just a distribution of the enrollment by cost level. Nearly 90% of our members are enrolled in either a cost level 1 or a cost level 2 clinic. As I mentioned, only 7% of our clinics are designated as cost level 1, but they have more than 25% of our total enrollment is in cost level 1 clinic. So it really does drive enrollment. Some of the advantages we see in running a tiered network compared to narrow networks is it really does continue to provide member choice. Members can continue to go to high-cost clinics, but they just will have to pay more in cost sharing to do so. And also, it really does hold providers accountable for the total cost of care and puts more responsibility on providers, and not as opposed to a high deductible plan, which tends to put more of the responsibility directly on the consumer. And some things that we're thinking about going forward with implementation of this, after 15 years of running this tiered network model, some other things that we're thinking about is putting more of these risk-sharing contracts in place with our providers to get them into lower cost levels. How do we implement better quality metrics into those contract arrangements, and making sure that, as Jeff was talking about, making sure that the quality measures that we put in place are meaningful and do align well with what other commercial payers are putting in place, as well as public payers. And we're also thinking about how do we implement quality metrics into tiering. So right now we are just using total cost of care for tiering designations. We're trying to think about, what are meaningful measures to put in place. Do we want to have a requirement that to be in cost level 1, a care system must not only be good on cost, but it must also meet some certain quality thresholds. Those are processes that we're really trying to work out right now. And we're really tracking the different types of alternative payment models that our TPAs are negotiating outside of our own strategies, whether it's bundled payments or other types of arrangements. And we're also interested in other types of value-based strategies, including reference pricing, centers of excellence. We are implementing a value-based insurance design for diabetes for next year. So we're trying to stand that up and making sure that it aligns well with the rest of our tiered network model, to make sure that we're not just waiving cost sharing in ways that undermine the rest of the tiered network model. And the team that I'm leading is really working to develop the analytic capacity so that we can really monitor these things much more closely than we have been. So with that, I look forward to the discussion and any questions that you have.
Thank you, Josh. We're now going to, in about 10 minutes or less, we have 2 questions that we're going to ask the panel to address, and then we're going to turn it over to the Q&A to the board. And there's a third question about taking some of these ideas and thinking about what we might do with PERS Select, or even a new plan to develop a VBID type insurance design. One other thought is the make or buy, because we do a lot ourselves internally with external consultant help. That is the CalPERS team. But if you look at what happens in Connecticut, they have to hire a third-party manager for the health component of their design. And in Minnesota, they use an external consultant to do a lot of the analytics in terms of the tiering. So the first question, and I'm going to start with Marge, is how do you address the differences between consumer point of view versus provider point of view for high-value care? A couple of sentences.
I'm not actually sure that there are tremendous differences between the consumer point of view versus the provider point of view. I think one of the great conundrums in asking consumers to look at trade-offs is I talked about the educational materials that they got, and one was a focus on low-value care and why it exists. And the biggest hurdle people had was recognizing that so much of low-value care was resting with physicians, that they do understand patients demand things and physicians sometimes knuckle under for any variety of reasons. But the fact is that it's still the physician in control. They have this tremendous trust in physicians as a group and in their own physician, and yet they're being told that so much of inadequate care is resting with physician actions. So if you ask physicians what's driving low-value care, I suspect they would point to, and correct me if I'm wrong, the demand patients make on them for things that they believe are right, the amount of time they have in an office visit to get things done, how little time they have to try to explain things, that it's simply much easier and faster to give patients what they want. But I think at the end of the day, the perceptions of what is low value is not dramatically different. I think there is generally trust in the research on why certain things are low value and we shouldn't be doing them. The question is, how do we get to a way to remedy this, quote, at the bedside, in the office, in a way that is consistent with the pressures they have to deliver care in a short amount of time. So I'm not sure whether I've actually answered that or not, but I think there's more they have in common with their view about low-value care than there are differences. The issue is, how do we get people what they want and still come away with a satisfied patient? You can have a satisfied patient, but a not satisfied citizen. So if we want both, that's where the magic is, the element of compromise that has to happen.
Well, I guess I would say, and being a clinician, the primary responsibility for understanding what the right thing to do is still rests with the clinician. And I would say it's the clinician's job, and I'm saying clinician, not just doctor, to provide options to the consumer in a way that they can understand and make informed choices. And I totally understand many of the pressures that are on clinicians in general, but I think a lot of what counts for practice is really habit, and in some cases being overwhelmed with information or not having access to it, and quite frankly not working within a profession, because physicians and clinicians can be often isolated from one another. So again, I'm back to my main theme. When you're in an integrated environment where you are being held somewhat accountable to your peers for the choices you're making, and you have information in front of you that highlights where you are relative to people that are actually being very thoughtful and thorough and have access to infrastructure that can train and support and bring new things to light, it makes a huge difference. And I'll just give one example. It's a commercial example, but it's one that I think is interesting. When you take the Choosing Wisely guidelines, as several hospital systems have, and embed them into the order entry system so that when the physician actually makes an order choice, if it doesn't meet evidence-based guidelines, there are systems now that can give not only a consumer-oriented view of what the alternatives are, but also just ask the question, are you sure you want to order it? It isn't consistent with guidelines. And these systems, even without being punitive or forcing people to not do what they think they want to do, they are avoiding all kinds of unnecessary care simply because at the point where that decision is being made, there's a reasonable check on whether that makes sense or not. And for those other clinicians in the room, I mean, this goes back decades. When I was a medical student, the lectures we would get, we called them camels because the lectures were so uneven in terms of their content. Some were long, some were short. There was no consistency across one medical school to another. You'd go train at one place and then go do a residency in another, and you'd be hearing different things. So I'm not saying it's a free-for-all, but I'm saying people do need the force of rigor and their peers to actually even know what they're trying to do. And then you throw in all the other things like worries about malpractice and direct-to-consumer advertising, all the things that we know about. But I still think the primary responsibility for knowing what the right thing to do somehow has to rest with the physician or the clinician, and they don't get that if they're not in systems that actually reinforce that.
So I totally agree with the other remarks. Just a couple things that I would add is something we've had to think a lot about is how do we make sure that we're providing the right signals, to both providers and to consumers around, where is high value care being delivered. So our current model of basing it on a total cost of care determination, in some ways I think aligns with providing high value care, but in some cases is still maybe a little bit too blunt, and we're thinking about how to refine that more over time, whether it's piggybacking off of the efforts of choosing wisely and other initiatives to identify low value care services, and how do we build that into our own methodology. Another challenge for us as well is how do we put better incentives in place that still build in on the intrinsic motivation of both providers and patients to do the right thing in all these situations. There's so many challenges when, especially in a primary care environment, of patient pressure on ordering certain tests and things like that we really have to think with a lot of nuance around programmatically what can we do as a payer to influence that in a way that we want to build on the training and the experience of providers who have the right motivations in place. It's just sometimes they work in systems that can undermine that in some ways. So it is a big challenge for us and something we're spending a lot of time thinking about.
Thank you, Josh. For the second question, I think we'll just fold that in the interest of time, to general question and answer sessions. So I hope the board has had a chance to see that we would like to seek the panel's advice on strategies that might be the best for CalPERS. But also I think that's something our board might want to answer themselves, what they think, having heard this panel, what they think the best strategies are for CalPERS. So I'm going to ask the board to help us answer this question. And then the third question that I wanted you to think about is we presented a sample plan design for a higher cost share PPO product that could be paired or not paired with a health reimbursement arrangement. And so we had a sample design very similar to some of the ideas that you've heard, both from Connecticut and from Minnesota. And we have very similar characteristics in the higher cost share, but with a VBID component that was added to it. Now, we want to continue that dialogue, but we also want you to think about what new attributes have you heard that might be useful in CalPERS adopting some of these VBID strategies in thinking about where we wish to go in the future with our own self-funded plans. So I'd like to now turn it over to the board, who's been very patient, and I thank you, to address questions to the panel.
Henry?
Yeah, thank you. I would like to thank the panelists for your comments and presentations very much. My question is for Joshua, and it's one is a general question and one is a specific question. The general question is that your last slide talked about what lies ahead, but I would like to go back and find out why did Minnesota choose the tiered approach versus the variant premium, and what did you find in your investigations and what led you to that decision? And my specific question goes to your chart on, I think it's slide 40, that's the health plan enrollment, and I think I heard you say that the plan did not cover retirees And then in this small section here, it says pre-65 retirees. So what happens to those members after they turn 65, and where are the retirees covered?
Great. Thank you for your questions. Regarding the transition from going from what we had before our tiering model to the tiering model, so that happened in 2002, and in the early 2000s, the CGIP population, just like a lot of other different groups, were seeing large double-digit increases in costs year over year. And one of the things that we really noticed was, we were having 20% increases that were just not sustainable. So we wanted to implement a new strategy that engaged the provider community. Before 2002, we ran a managed competition model, but we're contracting with some fully insured plans as well as some self-insured plans who were bidding in different counties, and then we would vary the employer contribution for health insurance premiums based on what plan that member selected. So a little bit like the managed competition model with the exchanges. But just found that really wasn't working to manage costs the way that we wanted to. And as part of that transition, we decided to go 100% self-insured. So we did that simultaneously to implementing this tiered network benefit design. And then with the tiered network, really trying to engage the provider community. We have a lot of cost variation in Minnesota. We have some communities that are relatively low cost, and we have some that are very high cost. We have I think everybody's aware of the Mayo Clinic system that is in Southeast Minnesota. That is a terrific place for tertiary care, but can be a relatively expensive place for more traditional primary care services. So just trying to think about how do we manage a cost environment where we have employees who are statewide in every corner in all different types of communities, rural, urban, and being able to engage the providers in all of those communities. And that's how we landed on this tiered network design. And then for your other question around retirees, so for traditional retirees, we offer a fully insured retiree product that is made available through our TPAs. And so when the early incentive retirees reach age 65, they have the option then to transition into that fully insured product. And that's the same for all the other traditional retirees as well.
Okay, thank you.
JJ? Microphone.
Sorry about that. I have a number of questions, but immediately following up on Henry, how do you think this would look differently if you had retirees in your program?
Yeah, I mean, that's a great question. I mean, we would have to think about our role as secondary payer, and especially working around all the Medicare rules. That's something I really can't speak to in a lot of detail because we just don't have a lot of experience with that. But I think that would be a major challenge for us to be able to run a coordination of benefits with another payer. I think also we'd have to think about our risk adjustment model. So we've been running a risk adjustment model that's been designed for a commercial population for the last 15 years. And if we were going to be having a profile of covered lives that are a little bit different, I think we would have to move to a different risk adjuster that can take into account a population that's over age 65, because I don't think our current model addresses that completely.
Okay. And again, on this slide, you talk about 127,000 members. Is that 127,000 family units or lives or?
It's covered lives. Yeah, so we have about 50,000 active employees in our population, 35,000 who work for the executive branch of the state of Minnesota. Then we have state colleges and universities, as well as some quasi-state entities who make up the other 15,000 employees.
Okay, so it's covered lives. And then on slide 49, which is the distribution of enrollment by cost level, some years there are really big changes. And I'm wondering, like the change between 03 and 04 is just huge. Any sense what happened that led to that kind of radical change?
Yeah, in 2004, we moved from having 3 cost levels to 4 cost levels. So I should have pointed that out in my remarks. What we found is that with the really wide range in total cost of care across all the different care systems. We wanted to have a fourth tier that dealt with those more outlier systems and put them into that special fourth tier. And what that did is it kind of shifted the other three tiers a little bit further down the spectrum.
And then in 5, your tier 1 went down. I mean, was that just reaction to the previous?
Yeah, I wasn't around to speak to exactly what happened in those years, but I would assume it had to do with the kind of the sorting out that happened after making that change in our designation of care systems.
Okay, thank you. And Kathy, you pointed out early on that perception is not the same as evidence. And I certainly agree with that. I think everybody would. But the reality is people react and make decisions based on their perceptions. And so one of the things we have to do is work at making their perceptions closer to the evidence.
Thank you.
Margie, you described the 10 sessions you did with, was there a difference between the groups? And what kind of were those differences?
Yeah, surprisingly little. We looked very closely at it. In fact, it's one thing that's in the appendix of the full report, which describes a number of things we looked at and showed quantitatively where there were differences in shift and which particular groups, by health plan, by age, by gender, were they evident. But I can't explain why, in fact, it was so consistent across all the groups. The choices they made, their responses to the pre and post survey questions, which is really the only way you can really look at to what extent was there a difference. Because when you analyze the groups in total, it's pretty hard to get an understanding of, how did this cover California group respond differently than this Medi-Cal group? The fact is, almost all of the issues they raised were very consistent across all the groups. One factoid of particular interest, because I often turn back to the C-section one, because that sort of stood out as people respond differently. It was in our first Medi-Cal group, which was maybe group number 2 or whatever, where it was raised, well, if women want the C-section and it's not necessary, then let them pay for it themselves. This is a Medi-Cal population. So finally I asked, but after hearing this in several groups, I finally asked them, help me understand this. You all know you're on Medi-Cal. Everybody knew they were part of Medi-Cal. By assumption, your discretionary reserves are probably fairly limited, and yet you feel strongly that women should have a choice, but you feel strongly that society shouldn't pay for it. How do you justify that given your own financial situation? And they said, because it doesn't matter. You got 9 months to raise the money. That they accepted the fact that this was going to be hard to afford themselves, but felt very strongly that a woman had a right to choose it, but she didn't have a right to impose that on the rest of society. So the fact that they really wore their citizen hat very seriously across all the groups. That was sort of a long answer. A simple question was there much difference between the groups or within the characteristics? And there was very little.
And you said people really did not like doing financial incentives. And yet we have a current system that has a whole bunch of financial incentives that may not be aligned with quality of care.
Well, what they really didn't like more than anything else was doctors being paid to provide better care. That was the one piece of the financial census that was particularly offensive to them, because it really conflicted with their views of what a profession is all about. They hedged their bets on that, though, when it came to patients making decisions or consumers making decisions based on finance. So you take the doctor out of the picture. For example, reference pricing, the CalPERS does. We didn't use that as an example, but it is a good example of what they would believe is perfectly reasonable. This is a patient or consumer decision. Do I go here for the colon cancer screening, or do I go here? Doctors told me I need one. Great, I accept that. But the decision about where to go now rests with the patient. So when you put the decision on the patient and not on the clinician, they think basically value-based design makes a lot of sense.
Okay,
Does
and-
that answer your question?
Yeah, that does. And Jeff, you don't get off the hook. You talk about it's important to look at the total costs of care, both what the plan pays and what the patient pays. Have you made any effort to try and capture the cost of non-care?
So I think you're actually asking a question about the cost of underuse and sort of the downstream effects. We haven't directly, but indirectly, we actually capture underuse in our performance measurements as well. So part of the statistic I said about 600,000 or 700,000 members actually in underperforming groups, much of that actually rests on organizations that are not providing adequate screening or adequate chronic care. And again, we can do that by geography as well. So it's very easy with our information to actually say, well, if I'm a diabetic in, the southern region of the state or the eastern region of the state, what does that look like versus the Bay Area or northern counties? And that all is about underperformance and under care. And they're pretty dramatic differences, like 30-40% difference. So I'd say you could find it. It's not something that we've put a bright spotlight on, other than to say start with integrated care options, because you're going to have a better chance of getting what you need.
And the question I promised you at breakfast.
I'm waiting.
And
Why-
JJ, we
Okay,
want to make sure we end on time, so
Let-
I want to give
let-
everyone
okay,
else an
Last
opportunity.
question. Why is value-based care not a step down the road to high deductible plans?
Well, I think the relationship between any two variables, and this sounds kind of wonky, is really how you define the variables themselves. So if there might be no relationship between charging somebody more for a definition of value that is based purely on brand choice or recognition or something like that, if you define high value to include cost as well as quality, then in fact there should be an inverse relationship. So the people that are spending less out of pocket are actually doing so because they're making higher value choices. And to reinforce what Joshua was highlighting, we use the same total cost of care definition. We apply it to 200 different physician groups along with quality. We have all the splits on sort of where the money's going. So it's one of those things where if you want to create, to kind of answer that other question, tiered versus narrow, narrow restricts choice, and that can work, but you have to be able to sort of manage the consequences of that. Tiered actually preserves some degree of choice, but you have to be very, very clear what you're tiering on and what people are expected to do. And I think if you are willing to take that on, especially in the benefit design, it can work. And in fact, I heard a self-funded employer just yesterday talking about pre-funding HSAs as part of their design, and actually what they were observing was, even though people had the money to cover much of their out-of-pocket expense, they were actually shopping with much, much greater intensity about where to get their services, what they actually needed, because they felt that incentive was there for them to actually start looking under the hood. The last thing I'll say is, if you're going to define value, you've really got to get what is under the hood of the plan that you're offering. So wide open networks where everybody is there. You've got to make some decisions about sort of where you want people to get their care, to the extent that those choices are available geographically.
Priya?
Thank you. So my first question is for Mr. Fengmeyer. You've acknowledged that really your system is really not focused on quality. It's really been focused only on cost, which I question whether that's truly a value product. But I guess my question for you is, have you over the years assessed the outcomes for members and maybe some key metrics around readmissions to hospitals and things like that to determine whether there has been a negative utilization impact of the tiering, or if there's a difference between the tiers in that regard?
It's a great question. It's a little tough for us to tease out the effect of the tiering because we have a plan that is at platinum level, over 90% actuarial value. And so it's going to drive a lot of the types of use patterns that I think you would expect with a plan that's that rich in its benefit design. So we do see that for a lot of screening service rates that we do really well because members, well, I mean, post ACA for a lot of these things are no cost sharing, but even beforehand, the cost sharing was really minimal. Our admission rates tend to be a little bit higher compared to benchmark populations. And so I think one of our interesting challenges is to develop a stronger benchmark to understand how much of these utilization patterns are being driven by particular tiered network design. So we ask our third-party administrators to provide better reporting on like groups, public employers in the state of Minnesota to really understand what's driving that. But in terms of like the larger quality picture, there are organizations like Minnesota Community Measurement that take data from all the plans and from many of the care systems to develop scorecards essentially for different clinic systems. And that's something that we provide that information to our members. We're not using it programmatically yet, but I think that's something we're very interested in. But and one of our challenges as well is having enough members at all the different care systems to understand the quality of care that they're getting. A lot of quality measures really do require a fairly large number of people going to that system to be able to get a viable quality score. And so we're really trying to think about how do we develop quality scoring based on our own experience versus having to partner with other organizations to pull in their quality scores. And that's something we're just continuing to work on and continuing to think about as we try to take this model to the next level.
Thank you. I would also be interested in Mr. Rideout's observations about your program, particularly given your earlier comments about integrated health care really delivering better value, significantly better quality at a moderately at a moderately lower cost. But what Minnesota has done is really put all their chips in the PPO basket, and I'm just curious of your thoughts and observations.
Well, a couple things I'd say. The product itself, the label, doesn't define where integrated care sits. So to the extent that there are integrated options, they can live within any product you want. And my point basically is find them, measure them, and make your decisions based on that information. And Kathy was saying, PERS faces a make-buy decision. I would say it's make-buy or use. We're providing, and certainly PERS contributes, but we're providing a lot of standardized information that people can and I think should use to kind of get that discussion started. So, but having said all of that, most of the integrated care options historically, especially in California, have existed in the HMO product. So what we're seeing is how well does that play in other products. And when I was at Covered California, I was actually pretty shocked with the first networks that came out that didn't have integrated options at all unless you went to Sharp or Western Health Advantage or Kaiser. What we're seeing now in our data is, to talk about cross-product, about 60% of the physician options, provider options in Medi-Cal plans in Southern California actually exist on the commercial side as well. So there's a lot more crossover than there used to be, and I think that's the opportunity to say, well, where do these organizations exist? Do they outperform the non-integrated? And how do I then use that information in a benefit design that actually provides people choice, but also makes them aware of what they're choosing between? I hope that answered it a little bit. Kind of.
Alan?
It's on. Now it's on, right? Okay. So in the interest of value, I'm going to try to bundle my question, like bundled payments. Is this on? Okay. Kind of directed to Dr. Rideout and Mr. Fangmeyer, but an observation on Ms. Ginsburg. My observation I understand very clearly what the study said about moving the needle, but it seemed to me a lot of the observations rested on the fact that the implications were very clear. It was very clear what they said about the bronchitis and the C-sections, and even the one about the cancer drug where $30,000 only extended life by 1 month. I mean, that was like an assumed fact in the problem, and I think it creates trust. Secondly, in the example you just cited, there's a very clear alternative in, say, the C-section example. if they weren't saving the money, there was still the opportunity for natural birth. So not being able to raise the money didn't mean that they didn't get care. It just meant they lost what I guess they perceived as an unnecessary choice. So the question I was going to was about just income levels and what they say for people's access to care. You said, Dr. Rideout, that cost sharing improves quality. And I know you cited a moment ago an observation about pre-funded HSAs. And Mr. Fangmeyer, I didn't fully understand the design, because I got the sense that if I lived in a rural area, all the providers were at the same level, so I would have the same cost sharing. But what you said about special deals in the presentation confused me until I thought what you were basically saying was there's a price factor in the model, and if you negotiate the price factor, it's easy to measure in the model. So my question is, in the research that you're talking about going forward, what is it telling us about cost-sharing devices where patients may or may not be able to afford them? And what is our research doing to help us get a handle on that factor and the problem?
Yeah, that's one of the key questions that this University of Minnesota evaluation is really trying to get at, is looking at for a member who is living anywhere in the state and has a choice set of clinics in front of them that do vary by cost level and the cost sharing, what are the characteristics of patients who make a clinic switch or who are less sticky, like with their current primary care clinic? And really trying to understand, is it health profile? Is it that people who are healthier are more likely to switch clinics and be more reactive to a change in cost level, and people who have a chronic illness that requires a lot of primary care management, they have an established physician, that they're just less likely to be reactive to a change in cost level? That's one of the key things that we're looking for, and the other demographics as well, to understand how reactive are people to a clinic switch. In terms of cost levels across the state, in those areas where there are just independent clinics, those are grouped together and the cost levels come up together. But in many cases, some of those are at some of the lower cost levels as well. So it's not necessarily people in rural areas just have options that are higher cost sharing. It just tends to be that cost level 1 clinics tend to be more common in the Twin Cities metro and a couple other regions. And that's one of the other things that's so important for us, is to make these adjustments to move certain clinics down to cost level 2 if a cost level 2 clinic isn't available in that community, to make sure that people have at least the option of a lower cost care system for them in terms of their cost sharing. So I hope that addresses your question.
I guess the only thing I'd add is you obviously can't penalize people economically if they don't have an option to choose a lower cost, or if they can't afford even that. I think there in California are some pretty gross distinctions between even north and south. So it's not really a rural urban, although there's a lot of rural communities in Northern California. So I think taking that into account, the other thing that I think I would suggest you think about is patterns of care are very different between integrated and non-integrated care communities. So the fact that somebody would be offered, say, a surgical intervention after a period of opioid use and lots of imaging for back pain may not even be how the front end would handle that type of case. In fact, in another example I can give you, by putting physical therapy on site at the employer sites, or by training the physician group up front, rapid access to physical therapy and suspending the limits on PT benefit actually proves to be a very, very cost-effective intervention and avoids lots of surgery when it's used. But it's not always something you can apply in every community.
Can you elaborate, Dr. Rideout, on just why cost sharing? I assume you meant cost sharing where, like, higher deductibles. Why that contributes to quality?
What my point was, and maybe I wasn't as clear, that if you are choosing value based on a combination of quality, patient experience, and cost, you could see an inverse relationship. You could incent people to use those higher value organizations and make their cost sharing lower as opposed to higher. So it's a form of VBID where your choice to go to a high value clinic actually accrues to you in terms of lower out-of-pocket costs as opposed to the other way around. I think sometimes people imagine, well, if I want access to everything, I'm going to have to pay more for it. And that may be true up to a point, but I think you can steer people toward better choices as a first step.
But am I right, it relies on the presence of a low-cost alternative that the patient can really get to?
Yes, there has to be something there to choose, I guess, if you're going to offer choice.
Thank you.
Jeree?
I'd like to
We have
start
We have a couple more questions.
couple more, okay.
Jeree?
Try to make this. I'll try to make this as quick as possible. But the question is for Mr. Rideout, and specifically, it's remarkable that your study has demonstrated that there's such a significant correlation between an HMO and high quality. And I just wanted to ask a couple questions about how you measured quality. Looks like they're outlined on page 2 of your presentation. And I wondered if you think this is a good subset to measure quality, or if there are factors that are missing. I think as CalPERS moves to explore high value plans, I would assume quality would be very important in that discussion, and measuring quality is important in order to determine whether or not there is that high quality.
Yes, I think what you're referring to, the subset of measures in the first round of the Atlas for quality was really small. It was only 6, but it wasn't random. It was chosen by our panel to basically say what would be most representative for a first round. We're actually tripling the number of measures in the second round of the Atlas. And actually the other thing that's really important is all those measures are exactly consistent in terms of how they're measured with what we do in the broader set for the 200 medical groups, which actually has over 40 measures. And when you get to the ACO set, apologies to Dave if he's back there somewhere, that set gets even bigger because purchasers are expecting more information and different types of information. So it isn't about necessarily getting bigger all the time, but it's about having a representative set that can actually match what CalPERS wants to do in its own data environment so that they can track as well. So it was a start. The other thing I'd say, last thing on that though, the diabetes measures are particularly important because in our analysis of our 200 medical groups, if you look at diabetes care, it's a canary in the mine for everything else. It's a canary in the mine for ER overutilization, for unnecessary hospital readmissions, for quality of care in completely unrelated areas. So in some ways, if a provider can handle diabetes care well, it implies a systemness of that organization that seems to spill over in many ways, not in all ways, not necessarily specialty care always, but it's a good early marker for like who's got kind of their act together in some ways.
Thank you.
Teresa?
Thank you. Thank you for your presentation. I appreciate it. I had a question for, I think Alan kind of got some of an answer on it for Mr. Fangmeyer. I'm trying to figure out, because we have a lot of members that are in very rural areas in Northern and Southern California, and they just don't have access to affordable health care. So how did that work? I'm reading here on, it looks like page 44. Well, on what page of, anyway. It looks like less than 10,000 member months. So tiered by region together with other independent groups. How did that work? Was that your rural regions and then you included other groups to drive that cost down?
Right.
Yeah,
It's
right
not-
there.
It's not necessarily a cost management strategy. It's just trying to come up with a viable method to assign all these independent clinics into a tier within our system. And so what we do is we identify all the independents, and then ourselves, we have a system of grouping them together into these regions and then pooling their experience together to come up with their tier. I would say as well, like some of these independents then do come to us to make deals, to accept a reduced fee schedule, and that can be beneficial to us and be beneficial to them at the same time.
Did you
being
have
able to
a-
drive some volume?
Did you have an analysis on how many came to you to ask? Because a lot of they're standalone hospitals with fewer doctors. So did they come, was there a large percentage that said, hey, we don't want to be in the highest cost tier. We want to be in a lower cost tier. So because they're kind of, patients are stuck using those facilities because that's where they live, or that's the closest facility. So did you have a fair majority?
So, again, we provide that access to cost level 2 for everybody. So there will always be a cost level 2 clinic within 30 miles of each work site. It does create our system, particularly the provider negotiations that happen over the summer before each plan year, do create some interesting incentives for providers. So they can either be proactive and come to us and work a deal out for the next year, or they can wait and then see if nobody came to the table to make a deal. And if there's not a cost level 2 clinic within that area, well, they could be randomly chosen then to be moved down to cost level 2 without having to give up anything. You know, they don't have to, if they're moved for geographic access, they don't have to accept a lower fee schedule or any of those things. So that does create a little bit of a tension that's probably more common in rural areas, just to see if there's going to be anybody who comes to the table and negotiates with us, and if not, somebody's going to be moved to cost level 2.
And I'll try to hurry on, I'm sorry. So, and I just want to clarify, cost level 1 is your least expensive?
It's the least expensive providers and the lowest cost sharing for members.
And we don't talk about quality in any of these cost levels?
Not yet.
Okay. So, and these are based on state employees?
Yes.
Okay. So are your state employees spread out in rural areas? So you do have work sites like we do, where we have prisons out at the border of Mexico and there's nothing out there.
Yeah. Yep. We have correctional facilities in some communities, and where there could be like relatively small, we have an outsized presence. You know, we could have more than 1 in 5 people with employer-sponsored insurance in that community are our members, and so providers in those communities are very reactive to their cost level designation because it drives so much of their patient volume.
Okay, yet you're still not really seeing, based on what you said before, you're not really seeing the rural clinics or hospitals coming to you and saying, hey, I want to be the one chosen. You're just, they're waiting to see, since they're the only one there.
Yeah, it varies. You know, in
Yeah.
some rural regions, they're much more likely to come to the table, and in others, they're more likely to sit back. There really just isn't quite a rule of thumb on exactly their approach in all those situations.
And then, I guess lastly, so, and again, none of this includes value-based care. It's more about the cost. Is that pretty much it? Because it looked like you did it based on claims data, risk scores, risk-adjusted, and efficiency.
Mm-hmm. Yeah, I mean, we've looked a little bit at correlations between the quality scores of some of the clinics who are at higher, or who are in like cost level 1, and there tends to be like a fairly strong correlation between cost and quality. It's just that we are not implementing programmatically quality into our tiering system at this time.
Okay. Yes. Thanks.
Just a comment, since we do include both, just so you know, we've not seen any correlation between cost and quality necessarily. So the assumptions you would make about, you know, who performs better on both are not always what you'd think they'd be.
They're not always there.
Right, and the other thing is that there's a very interesting distribution among rural counties in California as well, and especially if you look at providers, both in terms of the institutional costs versus the ambulatory costs. So I think to the extent you can get to that level of detail, you'll see kind of where the variation can be managed, as opposed to just
Right.
sort of people are stuck.
Yeah, because we do hear from members in the rural areas that they may be stuck at a hospital that they view as very low value in terms of how the care is managed and stuff, and they would rather go elsewhere, and they'd rather travel to go elsewhere that facility is so poor. So I don't know how this all folds into it, but I appreciate it. Thank you.
All right, well, that ends our time here. So Kathy, thank you and your team. JJ, you can ask your questions offline if we need to keep moving forward. Anything you need to add, Kathy?
I just want to thank the panel, and I
Absolutely.
want us to continue the dialogue and looking at where we might want to go in the future for value-based insurance design and some of the ideas that we presented ourselves, the team, for the PERS Select product. So there will be more to come, and I do want to thank this panel, and especially Mr. Fangmeyer, who came in from Minnesota to share his thoughts.
Thank you all. So we're going to take a quick 10-minute break, and we'll be back here to begin at 5 after 11.